Hello, everyone. A very warm welcome to this webinar. We are live now, and as discussed, we are going to discuss and mull upon acne scars. We have experts from all over the world, and I'm really privileged to be here along with all of the respected doctors. We have Dr. David Lim from Australia. We have Mark from USA. We have Dr. Nadir Kazi from USA. We have Dr. Emil Henningsen from Denmark. And today we are going to go over what the current status for acne scar treatments is and how each one of us is doing our bit to help patients with acne scar get over their problems. So the way we want to do this is we want to start with a round of introductions with everyone, and we start right from the time zone that's most ahead. So Dr. Devin will start and go on ahead. So that Dr. Devin, hi.
Hi there. Sorry, I've just moved myself so I get better bandwidth. Davin Lim, dermatologist from Australia. I'm glad to be here, and hopefully we'll answer some good questions.
Great. So I'm Dr. Dhanraj Chan, like I just said, from India, and I practice in Pune, majorly procedural dermatology, and I'm very glad to be here. Dr. Emil.
Yes, hello everyone. My name is Emil Henningsen, board certified dermatologist from Denmark in Northern Europe, and yeah, seeing a lot of acne scars. So I'm super happy to be aligned here in this forum with my good colleagues with this very important topic. Good to see you, everyone.
So the way we want to take this ahead today is I want each one of you to discuss what you love about acne scar treatments and what got you passionate about it, and where are you currently and how has your practice evolved over the past years. So Dr. Mark, we want to start with you. You are the pioneer in acne scar treatments, if we can put it like that. And how has been your experience about acne scars and where does it stand today?
Well, thank you. I've had a passion for the treatment of acne scars for over 40 years and have explored every possible way to treat acne scars, various types of scars. And that led me to inventing the Tailor Liberator Subcision device about 14 years ago. But I've also done many different things with lasers and other devices that some of them I was not impressed with their improvement. But I think the combination treatment that I do now, including multiple different modalities at the same time, for me has made a big difference, and for me and my patients. So I'm happy to be here. I love to help people with that scar because I know how devastating it is to their self-esteem and their self-confidence.
Thank you. Is anyone hearing a echo?
No.
No, right? Oh, perfect. So, Dr. Emil, can you take this up next?
Yeah, my passion in acne scars comes from basically, a desire to be able to see a difference. You know, as a dermatologist, you usually prescribe a cream and you wait for a couple of months, and the patient comes back to the out clinic to the outpatient clinic, and with their psoriasis there might be a slight difference. But when I trained in dermatology, I found this niche with all the energy devices, the lasers, and I kind of like that you could actually see immediately what you did with your own hands. And just like Mark Taylor says here, you make a difference to patients. This is a medical condition. It's not cosmetics. You're not trying to improve someone who looks normal. You're trying to normalize someone who has really a complication from a severe skin disease. So you make a lot of differences to people, and yeah, that's basically what it's about.
Yes, agree.
Dr. Nadir?
Sure, guys. Yes, thank you. So, I myself, a lot of people know about this, but essentially when I was growing up, I had really severe cystic acne, and pretty traumatizing for me. And I basically kept on cycling a bunch of creams all the time. Everyone said for the acne, do that. And I had to be on Accutane 3 times. And then I was left with scars. And then I had to do, I wanted to do something for it. Most people just turned me away. They said my skin color was too dark to do most things with scars. Just try a little tretinoin, they would say. Then I finally found a dermatologist who did Fraxel and microneedling. They did like 6 sessions of each. I was like really, really red like a tomato each time, and barely did anything for me. It really wasn't until like I started to really investigate this and get things with my own hands, discover Dr. Lim's work, discover Dr. Taylor's work, and realize that a lot of work really should be more manual work, like in terms of subcision, especially. And it really wasn't until I started getting those things done that I realized that I could really get my skin a lot where I feel much more comfortable with it. So it was a long journey with that, because it was really difficult to find. I was, I could go through a lot, but I bounced around multiple different places until I finally realized that, okay, there is actually some solution for even someone with my skin color. And a lot of it involves manual work, and that's why I emphasize. That's what I started with. I didn't really do, I have a lot of lasers now, but I didn't start with lasers. I started with subcision and TCA cross, those type of things, and Bellafill, that kind of thing. So that's really what my passion is, because I myself suffered from acne.
Nice to hear that. Dr. David.
Yeah, much like everyone else, I think it changes lives. Like Emil says, you normalize the patient. So it's not cosmetic. It's actually a medical procedure, which really brings the skin back to normal. And much like everyone else, it's the procedural side of things which excites me. It's the evolution of both energy devices and methods of how we treat scarring. I'm fortunate because there's a lot of pioneers before me, like Mark himself. Read all his papers, and I'm fortunate enough because Greg Goodman, who's also a very excellent scar expert, I worked under him, Phil Becker, and all. So I've been very fortunate where I've learned from others, including people like Prof. Go from Singapore, as well as how to treat darker skin types. So yeah, that's me summarized.
So when you say this thing where you're getting people back to normal, and that is what excites you about it, what are the challenges that you face about treating acne scars as such? We see some patients who respond quite nicely, some don't improve to that extent. What are your thoughts on it?
I mean, it's much like, I guess, the longer you've done this procedure or worked in the realm of acne scarring, you put everyone in the bell curve, because that's human biology. Sometimes you have these really acute, I call them, top tier guys, or the people who are hyper responsive and do really well. And then on the flip side, on the other side of the bell curve to the left, you have slower responders. So one of the challenges, I think, is to identify early who's going to be, who's going to be a slow responder. And sometimes you can predict, because they may have background inflammation with acne, sometimes with more maturity, sometimes they may have even underlying age-related changes of atrophy. They might have weight loss, they might not eat as well. And in many situations, it's genetic. So for me, one of the challenges is to identify these patients early, but understand there's a variability in the biology of skin and how they respond.
Right. Also,
Dr. Mark,
also extremely critical is not all acne scar patients are the same. It depends a great deal on what types of scars each patient presents with. Pit are very, very difficult to treat. Rolling scars are very common, and you've got the box scars, you've got hypopigmented scars and hypertrophic scars. And so the first thing I think that's so important is to assess the patient, what type of scars are in this patient, and what specific will benefit that type of scar. So each treatment needs to be customized to the type of scar the patient has.
right. Dr. Nadir, what do you think? What kind of scars or what kind of patients are the most difficult to treat?
Well, the kind of most patients, by and large, like acne scar patients, surprisingly are very, very well researched on just the different modalities that are out there in terms of like just the kind of results that you can get also, which I really love, actually. They do a lot of research in this subject. I myself did too, I did a lot of research on this. And I found that it was really a matter of just somebody listening to us and listening to what our concerns were. So if we we kind of actually knew what kind of scars we had. Like I knew I had rolling scars. And I knew kind of that like the lasers by itself weren't going to be enough. I think that the challenge is really just kind of connecting with the patient and understanding where, like, essentially that they are educated in the subject, they do understand where their deficiencies are already, that they're probably already kind of aware of like what treatment pathways to go through. The difficult patients may be very, very, very few in terms of ones that would expect like 100% result. But they're very, in my mind, I do several a day. Very, very few patients actually come with that expectation. Most people say during the consultation also that they don't expect that 100% type of result. What I try to achieve really for people is that they're going to feel comfortable, from a certain distance, where people at the, across the table aren't going to be noticing the scars. That's, I think, achievable, especially if we address all different aspects of the scar. So not just the texture, but also a lot of times volume. That's something that's really important. And for me, I myself focus a ton on just making sure the acne itself is under control before doing any treatment. I know you guys all do too, actually. All of you guys have all spoken about placing people on Accutane or low dose Accutane or doing something else to really make sure. And I think that's one of the reasons why the results are different compared to a lot of other practices, to be honest with you. Because you guys focus so much on controlling oil production and controlling acne. And, that's actually a bigger challenge than the scars sometimes, because sometimes just getting people to understand, I would love to treat your scars, but we got to control your acne. That's like the thing that's like a little bit difficult for people because they're so set. Like, I just really want to get my scars fixed. I'm like excited to get my scars fixed, and I barely get breaking out. But they don't understand that, like, yes, that little bit of acne that you're getting, it's going to get a lot worse after we do a laser. It's going to get way, way worse. And so I want to make sure that that's so controlled before we start treating your scars. So, it's like that comprehensive package, I think, is the reason why we could get that superior result.
Right.
So, Emil, like from what Nadir said, when you see a patient, what are the indications that you get that, okay, this patient is going to respond nicely to the treatments and this may not respond? How do you go about those decisions?
Well, to me, I think the most challenging patients are the ones who have some degree of aging, where you see, age-related loss of collagen, elastin, and also volume loss, deeper volume loss to the face. So patients with, let's say, subcutaneous scar tissue, tethered rolling scars, lipoatrophy from their inflammation combined with age-related volume loss to the face are the most challenging ones, because you can basically improve the scars, but you also shift your perspective. When you remove the scars, you start noticing something else. So these patients might be a little bit difficult to really improve because of the skin laxity and the natural sagging of the skin. So you might actually improve the scars quite well, but because you have this aging of the face, it gets a little bit difficult for them to appreciate what you actually do. So I try to address both issues when I do see patients, let's say above 40 years of age. We need to restore some of the deeper volume of the face as well for them to appreciate the improvement that you actually do in the skin.
Yeah, I would agree with that, and especially older patients who have severe acne scars. I will frequently add a fairly aggressive full face laser resurfacing to those older patients, because you also want to tighten the skin, get rid of the wrinkles. I also ask people if they get their moles off at the same time. So my goal when I get done is not only to help scars, but to make them look the best they can and have the confidence to forget about their life, happy, and addressing all of the companion issues that we can in our treatment, I think, is important, so that people feel like they've had a good result and can move beyond this damaged self-esteem.
David,
Sorry.
Emil.
Yeah, I had a patient the other day with acne scars who came from the Netherlands, And she told me that she had pretty bad acne from she was like around 18 till 25, and her acne finally cleared. And when the acne had cleared, she noticed her heavy upper eyelids quite suddenly. So you change your focus really, and that's another quite important a detail that we discuss here in this group, right? Because you remove one problem and you suddenly notice another. It's like restoring your house. You change the kitchen and then you suddenly only see the bathroom, right?
Right.
That's an interesting comment. I do a laser blepharoplasty on quite a few of my acne scar patients for that very reason, that it's an obvious problem, and if we can fix the scars and their eyelids and wrinkles at the same time, they really appreciate that.
That's correct. Devin, what kind of scars do you think are the most challenging to treat? So we know there are various morphologies of scars, and if you can, for the audience, cover the types of scars and which ones do you think are the most challenging to treat?
I think contrary to what popular belief, ice pick scars I think are relatively easy to treat. With either the TCA, the punch excision, which I do a lot, or like Mark does the erbium or CO2 drill down to the actual scar itself. So those ones, contrary to popular belief, they're not too hard. They're kind of predictable with that. The ones I think are the hardest are the hypo, as HYPO. No melanocytes there because of the picking acne scoriae.
Mm-hmm.
For those, I do melanocyte transfer, which are basically a split thickness not punch graft, but split thickness grafts, which are minced. Those ones are tricky because you've got your donor site, you've got to wait for those melanocytes to start producing melanin, which often takes about a year or so. So for me, the hypopigmented scars mixed with the hyperpigmented scars, super hard. Because when you try to use something like, either tacrolimus or some kind of prostaglandin stimulant or prostaglandin analog to stimulate those melanocytes, you don't want to make sure, you want to make sure the hyperpigmentation doesn't get worse as well. If you want to tickle them with a bit of narrowband UVB or Excimer, you may also stimulate the hyper. So I think those are really tricky, the hyper and the hypo.
It's surprising because like now that you see it, I've seen a video of you where you do the melanocyte transfer. In India, even though we have a higher Fitzpatrick type 4-5, somehow we haven't seen many patients with hypopigmented scars. Yes, there are patients with scars which are atrophic and there's scar tissue there which appears hypopigmented, but it's interesting, and I think that is something that we should be looking out for.
Yes.
Yeah.
When I see hypopigmented scars, if they're small enough, as part of the comprehensive procedure, I will actually, after doing the laser treatment, I will actually size as many hypopigmented scars as I can, if they're small enough that can be done. Maybe the size of a mole. Those can be excised quite well, and if you do it along with laser resurfacing, they actually heal over and hardly leave any scars. They heal very, very nicely. Huge patches of hypopigmentation are much more difficult, and there I think the melanocyte transfer or something like that needs to be done.
So, Nadir, which ones do you find the most challenging?
Definitely hypopigmentation is a challenging aspect, but I also struggle sometimes with linear scars. I think those were something that, there is something that people are talking a little bit more about, which is like other alternative options for these surgical scars. I'm seeing now, like people are talking about Porphin, something interesting potentially could do it, if you excise it and do it, but linear scars, especially in certain areas where if you know that if you excise it, it's not going to really heal as well. I think that's going to be a problem. I think like a scar right over here in the central area of the between the eyebrows, that could be a challenge. So I find that to be one of the areas that doesn't really, it's a little bit less predictable than, let's say, for example, like the ice pick scars. I think rolling scars are like the easiest scars to me, like just like very, very simple for me to solve. But like linear scars that, especially if there's like a little bit of volume loss underneath there, can be a big challenge. That's where I think some newer technology or something else may be needed at some point. Hopefully, let's see, because it's something I think all of us could probably see, like, sometimes when it's like you have really, really nice results and there's still that, like, that line that's still there somewhere. You know, it's like that's that one a little bit of a challenge.
I would agree. The linear scars are a challenge. Uh, just last week when I was doing, and I had this patient with linear scars, and I think Mark's technique where you drill down would be something that would should be tried in these kind of scars, because when you do it alternately, like the fractional thing, like what Mark you do with the port wine stains, the fractional way. Similarly, if in the linear scar it's done, that may be one way to look at it. Emil, what do you think?
Well,
The most challenging. Yeah. Yeah,
go
Mark,
ahead.
sorry. No, please go ahead. Yeah.
You asking me? Yeah.
Yeah.
Yeah,
What?
definitely the hypopigmented scars, for sure. I mean, there are also certain locations of the face that are quite challenging, like the tip of the nose, right? Because you have this lot of stretching of the skin in all different directions, so it's really difficult to shrink the scar surface in certain areas of the face where you have a lot of tension to the skin. So yeah, it's about the morphology, but also about the underlying inflammation, as we discussed, and the location of the scars.
If possible, on linear scars, if you can excise the linear scar in a way that you're with the tension lines in the face, so that it fits like a wrinkle or something like that. Sometimes you can get really nice results if you're doing it at the same time you're doing resurfacing. I had a patient who had a linear scar across the entire forehead, and so we basically took out the entire line from side to side. And 2 years later, he looks normal. He has a slight forehead line that looks in a normal position. So if you can align your excision along with the tension lines, then that can be a very, very nice result for these linear scars.
I saw someone who was saying about chickenpox scars. That's also a challenging thing, especially in darker skin types. What are you guys doing for, especially let's say Fitzpatrick 5 or 6? What do you think about chickenpox scars, the wide ones, thick ones?
The wide ones, I think, would be subcision and some filler, so maybe biofiller or fat. The smaller ones, we can still attempt excising it, punch excision. That's something we could go for. So it would depend on what size they are, at least in my case. Devin?
Yeah, I mean, I actually did some reading up, funny enough, just last week. When you look at the evidence-based medicines, there's an article which was written 3 years ago, 2021. I totally disagree with what the article says. Basically, the use of TCA cross. The chickenpox scars are way too big, way too big. You're going to run in so much trouble with TCA. So I find those hard, like Mark said. They're hard scars because they're wide. So the other thing is, well, they occur a lot in the forehead area. What's puzzling about chickenpox scars, when you look at histology, we know it's an intraepidermal vesicle, right? But then the scarring is so intense. We get the infiltrate, the intense lymphocytic infiltrate below. It's much like, nuclear dust when it explodes. So even though the vesicle is within the actual epidermis itself, the scar is often tethered. It's often wide, right? And it's often in high-risk areas like the forehead. And so lately I've been doing subcision using a needle, but there's this new injectable, a new polynucleotide. So I'm doing a whole series on something called Regeran. I don't think that's going to be the absolute answer, but it's much easier than doing something like a dermal filler. Because with a dermal filler in high-risk areas, especially chickenpox scars covering the entire forehead, you're pretty nervous. Your concentration span's got to be there for 15 minutes when you're actually filling up those scars. So with the
And when you want to
polynucleotide,
be in the dermis.
yeah, and with the polynucleotide, there's no reported intravascular occlusion with that. So that's something I think I'm mucking around with. It might be better than any of the other things like TCA.
All right.
If there's
So
there's a manageable number of chickenpox scars, I always try to excise them, because the chickenpox scar is so scarred and sclerotic. It's very hard to fill, and it's very difficult to improve it with lasers or any other energy technology.
True.
Yeah. There's a question about phenol peel. Like, is phenol peel the strongest thing? What's the opinion? Because most of us tilt to either TCA or phenol, and phenol in itself is a different league altogether. So, in what kind of scars do you try it or do it, and what Fitzpatrick types?
Well, I mean, I think it's Fitzpatrick 1 through 4. You could do it in. My population tends to be Fitzpatrick 4 and above. A lot of patients, but I think probably it is definitely the strongest. The question I think was, is it the strongest peel? Yes, it's the strongest peel. There's no question about that. But I think the problem is that people don't understand you have to do other modalities with it, and there's like this misconception that you just do this phenol peel and you just get this new skin and like that's your skin. And I think there's this micro swelling when they're doing a lot of these results, and certainly if you get a very nice result, but it's not like this end all be all without, if you're not doing like fat transfer or Bellathil or Radia sculpture or something else that you're going to do for volume. A lot of times you have to do subcision as well to help lift up the scar. So usually we're lifting it up beforehand, and then we want to do the phenol peel and then do some volume later on. I think there's a bit of like a confusion because you can still get very, very excellent results with lasers in the right patients. And you could do that even in darker patients than you could potentially with the phenol peel. The catastrophe of, as we all were talking about earlier, of hypopigmentation, I think is very, very real with a phenol peel, more so than with a laser. So you run into that risk with darker patients, and it tends to be the darker patients, Fitzpatrick 5 and 6, who are asking for phenol peel, interestingly enough. And so it's like they're the ones that you 100% would not want to do that on. And so I think there's a bit, I don't know why, there's something maybe on social media or something like that, but there's something out there that people tend to think that that's the solution if you're darker skin. And I think it's the opposite actually. And it seems to be like you think that that's all you have to do. And then it's like, that's not all you have to do. So you still have to do other things. You still have to do other treatment modalities, which we all talked about. And I think we have to educate people about that, because it's like I get questions all the time about just do phenol peel. And I don't think that people are understanding that that's one portion. If you want to do that, that's you're going to have a lot more downtime. We're going to have to do it in an OR setting. You're going to be very, very red, like a tomato, potentially for like a year. And yes, it's going to be great, but like you, just as long as you accept that those are really the, if you're signing up,
downsides to
understand that's that. And I could get you to heal a lot faster and get a beautiful result without that, with lasers. So just I think that education has to be there for a lot of patients.
Mark, what would you say about TCA as compared to say phenol? Also, when we put this out on Reddit, there was a question about TCA that a lot of people are reporting that with TCA cross, some of the scars may get larger. So, what's your whole take on TCA?
Yes, I don't use either TCA cross or phenol for pitted scar. I like focused ablation, and I'll tell you why. When you put TCA into a pitted scar, then you have to wait for the chemical destruction of the lining of the pit, and then after that, hoping that the skin will come back together and be smooth. I've seen from other patients who've come and had it done that they have had widened scars, and also the process is cumbersome. So I've gone focused laser ablation of pitted scars, and healing can start immediately, and usually it will heal completely over within a month or I want to make an ablation larger than 1 millimeter. If they're larger pits, I think they're best excised. And so I'm not a big fan of TCA cross or phenol pitted scars.
So, you prefer the new technique that you were describing, because there were questions about that too. Like, can you elaborate maybe a bit more on it?
Okay, so pitted scars are an acne pore been destroyed, and then the hole is lined with epithelium, so it cannot close. And patients with extremely oily skin, not always, but frequently. And so when you get acne scar, the pore gets expanded and then relined with epithelium, it stays open, and that's a big problem with people who have that type of skin. So my feeling is if you can immediately ablate the lining of a pitted scar down to and in the dermis, if in fact even completely through the dermis, then the healing from the sides has less damage than if you put a there. And the healing can start immediately. I also do many patients that way for sebaceous hyperplasia, and they almost always heal with no sign or no scar at all. So, because of my experience treating sebaceous hyperplasia, I pioneered this area of pitted scars. I'm very happy with it. I'm very optimistic about that making a big difference in people with hundreds of pits.
Thank you. Thank you for that. Emil, do you want to take this question? There's a question about subcision using blunt tip versus needle tip. So if you can briefly summarize what subcision is with respect to the levels and also with respect to the devices.
Yeah,
And
sure.
Devin, you can take that up after Emil.
Yeah, and it's a super important question actually, because subcision is not one entity, right? We have so many different tools. We have different layers of the skin we subcise. Basically, if we talk about the layers, we can subcise in the dermis, in the skin, which I like to do for, let's say, saucer scars or chickenpox scars, where I subcise actually in the skin layer. If we have subcutaneous fibrosis, which is bands of scar tissue that connect the skin to the underlying structures like the muscles or the fat, we need to go underneath the skin to subcise and cut loose those tethers. So subcision can be done in different layers, and it can be done in 2 layers in the same day, because sometimes you have the full thickness fibrosis. So you need to deliver the best possible results when the patient is there. So we subcise in the skin and we subcise underneath the skin in the same setting. When we subcise in the skin, I like to use a plain needle, a 27 or 25 gauge needle, and the patient would not really need any numbing for that. It's slightly uncomfortable when you penetrate through the skin, but you don't have a lot of sensitivity in the skin actually when you subcise. And then you can immediately, following that procedure, using the same entry port, subcise in the skin and inject a little bit of potentially hyaluronic acid filler. When we go deeper, we want to control the bleeding, and it's also a little bit more aggressive to the patient. So we like to numb the patient. We inject local anesthesia. And obviously, the patient will swell when you inject the local anesthesia. So we like to mark the areas of depressed scars before we start doing the procedure. And then we can use different devices to subcise underneath the skin. We have the good old no-core needle, which is a sharp device that I like to use for individual deeply tethered scars. We have Mark Taylor's invention, the Taylor Liberator, which is also a sharp device. All of us know it and work with it on a regular basis. We make an entry port somewhere in the face, and then we subcise larger areas, but we don't want to subcise areas that don't need to be subcised, right? So we try to do it in a controlled manner to subcise the subcutaneous bands in areas of atrophic scarring. Then we can also use a cannula, and the cannula is a blunt device. It has a round tip. I usually say it's like my finger, and we cannot cut through anything, but we can try and force this blunt instrument through those subcutaneous bands of scar tissue. But it takes more treatments to get the same results as when you do it with a sharp device, where you can completely undermine the scar. And it's more gentle to the patient. I hardly see any patients with hematomas, hardly any bruises from cannula subcision, and we can use something to compensate for the volume loss immediately following the cannula subcision, because you don't have a lot of bleeding and oozing. So I like to use anything from dilute hyaluronic acid filler to biostimulators like calcium hydroxyapatite, PLLA, immediately after the cannula subcision, which I don't do after the talar liberator subcision, because you inject a lot of tumescent anesthesia and it needs to drain out. So if you inject something immediately after, you can't really let it stay there. You'll expect it will drain out. So yeah, it was. I hope it makes sense, but it
does, and it covers it very nicely the way you explained the layers and the
subcision is basically one word, but it's so many different things, and that I think that leads to a lot of confusion, basically, because it's different instruments, it's different depth.
I think confusion and also maybe disappointment, because subcision as a treatment, even on real self, has one of the highest ratings in terms of satisfaction for patients with acne scars. So we've seen how patients can be benefited from it, but because different people call different things the same name, maybe that leads to the disappointment. David, would you add anything to it?
Emil has covered it very eloquently, and he's absolutely right. My registrar and I just did publication last year. We published in Derm Surge about the different instrumentation. So we covered everything what Emil said, everything from cannulas to even Niti Kunja's bent needle technique to Greg Goodman's larger size hypodermic needles, all the way to Mark's larger caliber instruments. So I think it's just a whole heap of instruments, and the main aim is to pick the correct instrument for the job. It's much like I say, we're almost exactly like carpenters. We're just technicians. So we're working on skin. We pick our tools based upon what we need to. In some situations, we need a sledgehammer. In other situations, we need a very small hammer. In some situations, we need a screwdriver. So, subcision per se, using different instrumentation, should be matched upon the job itself. And then, much like you get a haircut from a hairdresser, it's the skill of the person cutting the hair using an instrument that gives you the results as well. So I teach cannula to begin with. I almost exclusively do sharp, and the sharp I do is very sharp. But then, I try to teach cannula because it's a safe way to actually start off with, especially if the doctors are learning. And then from there on, get the feel, and then, like Emil says, probably use a hypodermic needle, go up to your no-cause, and then from there maybe your Toledo's, and then from there to Mark's instruments. So it's a graduation of understanding the feel for the give of the scar, and understanding what depth you're at, and matching that instrument to the patient himself.
So Kenna's over here in the comments saying subcision is subcision, no gaslighting, please. So I think what she's probably, or he is referring to, is regards to the consequences of subcision, which I think is like a very, very hot topic, which we really need to talk about. So as I was talking about in the beginning, like I'm fully aware of just the different modalities. I underwent Fraxel laser, I underwent microneedling for my scars. It really wasn't until I had his name is Dr. Fadi. He did subcision for me. And he also the one that trained me in the method too, and he used multiple different tools to do that I really ended up getting the fuller result. So I don't believe that like it's something that we should downplay, that there's some potential consequence that people could have, but when done correctly, it can be really, really life-changing. Really, it was for me. Certainly, like I'm not going to downplay again like what other people can experience, but like for me and my patients, really, it really is something like I don't know how else I'd be able to achieve that kind of result. Certainly, it's not going to be with back in the old days type of thing of Fraxel and microneedling. It's really with like Dr. Taylor's Taylor Liberator that we were able to break up some of these bonds, and I'm able to break up some of these bonds. It's either with Dr. Lim's techniques, Dr. Emil's techniques, these type of things for subcision that we've now really been able to learn a lot with in terms of going underneath there and doing different layers if we need to. For patients, by and large, vast majority of patients, we do need to do something to break up that scar tissue. There is some tethered form that is with these scars. Even if you do all the energy devices in the world, you're never going to be able to achieve, the full correction that you could get. And so, I would hate for us to really set everything back because of a concern. Even though I understand that people have this concern among my patients, we now did a review. I randomized it with 75 patients or so, and we have had 0 complications of sagging. I've talked to everybody here. Nobody has had objective evidence of sagging. The big consequences were one patient had one mild form of hematoma, which lasted about a month, where some swelling from that, and then afterwards resolved with that particular patient. And then there's, of course, we had to do combination sessions like redness, things of that nature. But when you collect the data, we just haven't seen it. We just haven't seen objective evidence of it. And I think it's important really just so that we have that discussion really and just talk about the fact that if we really were to shift away from subcision, we are going to go back to just energy devices, which I don't think is going to help out anybody. Our goal is really that we want, of course, not just the best result, but the safest result. So if there's anything here that we're finding that, okay, this is something that's not going to be safe enough for patients, the risk benefit ratio isn't there, then of course we could shift that, but of course we can now say, all of us, we're going to be totally, this is unsponsored, but it's not like we could 100% be able to shift and change our methodology and figure out the best possible way of doing something. But at this point, based on what we have, and we're very, very meticulous in doing, I've seen all of your guys' work. Every single one of you is very, very meticulous as you do the subcision, and very careful with it. And that's the way to do it. I mean, and I think that's why we don't really run into that problem. I think we just have to be clear that there's not I don't want to go back to Fraxel microneedling, to be honest with you. If it didn't work for me, it's not going to work for patients. I don't think that we should be going to that dark age type of thing. And, we've advanced it so far. And I think there's so much more room to advance it. And let's have that conversation how we can advance it.
I would agree to that. Mark, do you want to take it up? Because you have helped, you have developed this technique, and if it comes from you about your experience, I think it brings a lot of weight to it.
Okay. So with me, subcision really releases the visible surface of the skin from the underlying scar bands. And the other thing I've realized, scars that you see is only a part of the problem, because there's a field effect of scarring underneath the skin that is far beyond what you see on the surface. And so when we invented the Tailor Liberator, I really wanted to level the entire zone where there's severe scarring and release it from the underlying dermal scar. If you look at the Tailor Liberator carefully, the tips are actually blunt because it helps prevent perforation through the skin when doing subcision. And you really only need to do subcision in those scar zones. When I do it, I always use tumescent anesthesia for 3 reasons. One is that it stabilizes the skin so you can be more accurate in the level of subcision. And the most important level is the base of the dermis, the top of the subcutaneous. The other thing, with tumescent anesthesia, I double the lidocaine so that I have extremely good hemostasis and really good anesthesia, so the patient is not uncomfortable during the procedure. Something else that I've done in recent years is, after doing, we hold pressure on the skin for 5 minutes so that we reduce the risk of any hematomas after doing an extensive. Since doing that, we've not before that we would say we'd created when doing subcision. Also, in the past, I would put a thermal stimulant in the subcision area.
Mark, your voice, I think, is a bit, it's breaking at my end. Is it for anyone else?
Yes.
A bit.
Would it help if you disconnect the video, the camera, so we can only hear your audio?
Is there another video going on in the room? Is anyone else watching the live in the room on any device? No, right?
I don't have anything else going on.
Now it's perfect.
But anyway, also I put steroid in my tumescent solution to reduce some of the inflammation and reduce any operative swelling. And when we do a fraction laser along with a fully ablative laser, I usually put something like PRP and Sculptra on the surface of the skin to stimulate faster, more complete healing. So we've made modifications along the way that I think all have helped us to get more improvement in a single aggressive
Thank you for that, Mark. Another thing that I want to take up is from the discussion is very popular right now, and it's coming up in a lot of discussions, is verteporfin. So, what is the take on that? And David, if you want to take this, what's the research on it? Does it have any role right now in acne scars? Do you think it will have any in the future?
Yeah, I think so. This one I'm going to pass to my colleagues because I just don't have enough experience with it nor knowledge to actually give a an answer which is going to be which is going to be representative of what it is. So guys, you can take this up from me. I have no experience with it.
Yeah, I think it's really early, really early stages. And I know I've been talking to a lot of the people within the verteporfin community for a little while because when I was doing lives, I was getting a lot of questions about it. It was something that I myself was not aware of. And I just started hearing about it more and more about some animal studies. It sounds interesting. There's a physician who started to do it actually over in New York. I heard now also in Greece. And it's the possibility of scarless healing, which of course will be amazing if we can achieve it. It'll be absolutely amazing. Really early stages though. From my end though, I think that there's a lot of questions, of course, about safety, about the dosage. There's also difficulty acquiring the drug. Right now, I'm actually in the process of trying to get the drug. It said that there'll probably be a few weeks out before we can get it. But I'm open. I'm 100% going to give it a shot because I think that the initial possibility of excising the scar and then using verteporfin to get that fuller scarless result would be amazing. But there's also a possibility that we could do it even with laser channel holes or microneedling channel holes. It's very early. I think that we're like a couple years out before we really have enough information about this because it's something that's only been done in animals, only done by like a few people now, just like on their own, they were able to acquire it. We don't really know much more about that, but like, of course, all of us will be interested if we could get scarless healing. I mean, who wouldn't want that? So if we could achieve it, let's do it.
If you can help me understand, most of the studies that are there is for scar healing, right? When there's a wound and you want to heal it without a scar, that is where the studies are. What I'm not able to yet understand is where in acne scars does it stand? Are we talking about doing energy-based devices and doing micro injuries and letting them heal, or where exactly does it stand in terms of mechanism also?
Well, the thing
as per the understanding right now,
yeah, the way I'd be excited about it, like I was talking before, is linear scars, excising that scar, and then actually using verteporfin potentially for that. I think that'll be something that'll be really interesting. I think that's the first thing I'm going to be starting. Chickenpox scars is another option, essentially excising that chickenpox scar, the wide chickenpox scars, and then hopefully we can see if that skin could grow. Like I said, the reason why there's a hesitancy with what I'm saying though is I wonder though, at what point is it going to be hypertrophic? What other consequences are there? Are there other potential consequences, for example, malignancies? All those type of things are really important to investigate why it has to be really robust. I know that people are excited about it. I love the fact that people are excited about it, but like at the same side, for our side, we have to be very careful for making sure that these are as safe as possible for humans. There is a physician right now who's doing it actually for hair transplant scars, and it seems to be working really well. That's interesting. I mean, that's something that I think, it's very early, but let's see if this is something that we could do. I think all of us will be like excited to do. There's nothing that we're going to hide that like we would want to get scarless healing. That would be like amazing if we could get scarless healing. So of course, we're going to see if this works.
Perfect. Anyone else has to add anything on this particular drug? What about Procell? Procell, I'm hearing for the first time, but anyone heard of what Procell is and Procell microchanneling? There's a question out there. I guess no. So in terms of understanding where we stand in terms of energy-based devices, where is it that you use them, and what are the limitations of it, and what are the advantages of it? If we can go one by one, because that's something that is very interesting. a very few dermatologists actually do manual procedures. Most of them rely on, say, in India, the fractional CO2 laser or MNRF. So radio frequency microneedling, those are the most common things. Many dermatologists also don't do subcision in itself, even the basics ones. So where do energy-based devices stand? What are the advantages and what are the limitations of it? Anyone?
Yes.
Devin?
Well, I mean,
Mark?
when it comes to certain scars, your energy-based devices are standout. For example, if you've got post-inflammatory hyperpigmentation, resolution of that, whether you use your picos or your Q switches, your vascular stuff, so your erythematous, your red scars, and macular erythema, they are pretty much standout. In the context of the other type of scarring, the reason why I guess you have energy-based devices and a lot of people use them, they're standard operating protocol driven devices, what I call SOP devices, which means, an esthetician can buy one, a cosmetic physician can buy one, a dermatologist can delegate. So from a I guess, from a revision point of view, they may give a more cost-effective method for patients with scarring, and especially with the newer RFM devices. Now, will it address rolling scars like what you guys have mentioned? Probably not, right? So, but they do have a role for certain things like boxcar scarring, superficial scars. I think they've got a role. They can be useful adjunctive treatments for things like rolling scars, especially in darker skin types when you're using RFM. So is it better than nothing, or is it better than cold microneedling? The answer is probably. It is, right? But is it the gold standard when it comes to revision of scars? The answer is no. Because as we all preach, you have a look at the scar signature and you match that particular method based upon the scar signature, whether it be ice pick scars, rolling, all that scars that we talk about. So they do play a role, but I think they play a limited role, especially when it comes to rolling scars.
Thank you for that. Mark?
Yes, I have a lot of energy-based, along with when I have scar bands, I think subcision is critical and maybe of the improvement. The surface has a lot of stuff. Any patient, um, they older wrinkles, dislocation, many other things going on, and so the energy devices help the surface of the skin. They don't. They're the ablation, for example, in a patient who's 50 years old with bad acne scars and wrinkles is phenomenal because you tighten the skin, you smooth the surface, and along with subcision, gives these patients a tremendous improvement. I love energy-based devices, as we've talked already, in ablating the pit. I also like to use energy-based devices in a focus mode for elevated scars, for the borders of box scars, and to smooth whatever I can in terms of uneven elevation changes that go along with the scarring. So it's all important. And it's important to look at the patient and see what's going on. If you have a lot of surface bumps and unevenness, then doing something on the surface that matches the need of that patient is very, very important to get an overall smooth result.
Right. Emil, I've seen you use the radio frequency microneedling quite aggressively, and you have some great results with it. What is your take on it?
Yeah, I think there was a new study published by Professor Merete Hedersdal, the Copenhagen group, recently, where they compared the ultrapulse from Luminis with the expert settings, fractional CO2, with radio frequency microneedling. It was the Lutronic Genius device. And they showed comparable results, but better outcome when you looked at the complications and side effects in favor of the RFM. And it's actually what I see as well. I don't use fractional CO2 as much anymore. I prefer to use radiofrequency microneedling for most deeper scarring, most hypertrophic scars. Where I like to use the fractional CO2 is more for the pitted scars, where we like to ablate the skin surface. I prefer to use CO2 or erbium fractional or fully ablative laser resurfacing for that. Then when it comes to ethnic skin types, darker skin types where we have melanin, we can use the 1064 Q-switched or Pico laser for those patients, or of course for patients with hemoglobin as a chromophore in the skin redness, we have our vascular lasers. So I like to think of energy devices as support tools for me to my manual work when it comes to scar revision.
Thank you. Nader?
Yeah, I mean, that is exactly correct. The manual work is what we kind of emphasize over and over and over. I kind of differ from a little bit from a couple of you guys. I do a lot with like TCA cross, a lot with, I do a lot with subcision, of course. But though, my darker skin types, I think do really well with manual work, though, lifting up the scar. And then especially for like those hard edges, nothing's really going to be able to beat a strong laser at that point. Then, if you have to go ablative for the edges like that of the scar, then that's something I would do. And then I blend it up with more of a fractional laser. But I can be totally honest with you, that's just like kind of the last part of it. Really, it's more of the other aspects where we have to give you something for volume. We have to give you something for breaking up the scar tissue. We have to help lift up the scar, especially the deep aspect of the scar, because what are you really going to be able to do is, to your point, Dr. Emil, and to your point, Dr. Taylor, essentially you're not going to be able to go all the time for dark skin types and go all the way down to the deepest portion of the scar. You got to do something for something else for that aspect of it, which is why Dr. Taylor is using like a small focal point of the erbium to drill down for that. He's not going like completely ablative for the entire skin everywhere going down to that level. I think you're going to run into a lot more risk for darker skin types. So whatever tool we're doing, we're trying to be cognizant of the fact that we want you to heal. We want the safety. We also, of course, want the result. We want that result, but at the same time, it's like, especially as we deal with Fitzpatrick 4s and 5s and 6s, we got to be exceptionally very, very careful with these energy devices. And so it's kind of like a part of it, but like it's like the last part of it in a way, because it's like, yes, it's important, but like we got to do the other things. And I always emphasize, especially volume. We really want to make sure that we place enough volume in there, because a lot of times when there's, especially with the rolling scars, there is a lot of volume deficiency. And you have to do something for that volume, whether that's, like I said, Bellafill, or that's fat transfer, something that needs to be addressed. Otherwise, you're really not going to be able to get more of that complete result. Even if you go ablative like crazy, you're still not going to be able to do that.
Right.
Thank you.
Dr.
Dr. Dharnash, you have so kindly been hosting this, and I know you're a very humble guy, but you're also very skilled. Would you have anything to add in your treatment approaches with subcision? I know you use fat transfer as well. Is there anything you'd like to tell?
I think most of the things we all do is similar with different approaches. But yes, fat is something that I do quite a lot, and it is injecting fat. Of course, like it would appear in subcutaneous fat atrophy, but I also use a lot of fat in intradermal atrophy. So when there's intradermal atrophy, I use microfat to inject it after the subcision. So it acts like a spacer. And what I assume is also the adipocyte stem cells in it after the laser. So I do a fractional laser deep, and then do the subcision and inject the fat. What I assume is the neocollagenosis that's stimulated will be helped by the adipocyte stem cells in it, and the spacing, the cells will act as a spacer. Of course, over a period of 1 or 2 months, the adipocytes are not going to survive there. They are going to get reabsorbed, but the stimulation will keep on happening. That's one thing that I do differently, and I do quite a lot. Apart from that, it's almost the same everywhere. There is bi-level subcisions in each patient that I do. So if the patient requires either a blunt cannula or a talar liberator plus needle subcision in the dermis, that's most of the things. Otherwise, it is similar. What I really want to add and put out as a message to patients, and I want each one of you to do it after, because we are towards the end of this, is that patients also need to understand that we have the intention is right on our part. We want to help patients get out of the scars that they have, and that basic intention patients need to understand. It's not always about money. with respect to the limitations, there are limitations. It's in medical science in general. Each patient responds differently to the various treatments. So that is something that we need to realize. Doing the same treatments or similar kinds of methods for each patient, the results are going to be different in each in every other patient. So that variability is not in the hands of us, the doctors. Genetics play a role. The healing plays a role. So that's the only understanding that patients should have, and the belief that when we go on to do any treatments, it is with a very pure intention of making the scars better. That's all. Yeah.
I
So
wanted to kind of, if we could quickly just have this question that someone that Kana was asking here: how to break up fibrosis from subcision. Do you want to go into that? I think you mentioned that before, Dr. Dunraj, or Dr. Taylor also was talking about it
So
before.
break up the fibrosis from subcision. So subcision is used to break the fibrosis in acne scars. If we are referring to the fibrosis happening post subcision, I think intralesional steroids would be the answer for that.
yeah,
Yeah.
I don't really feel like I have to do anything after the in the patients that I'm seeing, other than immediately trying to prevent any hematomas. That's the greatest risk with extensive subcision, and if you can prevent that, uh, typically they heal very, very nicely and very quickly. Don't have additional, um, you know, volume creation beyond what they would like normally. And also, I've never seen sagging. We mentioned that earlier. This doesn't really cause sagging. It's separating at the subdermal level, the surface skin from the underlying. So I once in a while I'll see a dermal nodule develop after subcision. I think there's that occasionally happens, but I rarely have to treat that. It resolves within a few months without any additional treatment.
Makes sense. Mhm.
And then I saw this question here: which will help in improving collagen boosting, which will result in less number of treatments, better looking scars, improved skin textures? Anyone want to answer that one?
I think this is with respect to the various fillers that are available. If you scroll down, there's
Okay.
a question which was put in before this, and this is a follow-up question to that. So, of the various kinds of biostimulators available, which do you think is better in terms of boosting collagen?
Let's do that then.
Personally, I like to use Sculptra or Glute. I have a problem with plastic bead, the PMMA. I have seen some patients with long-term granulomas after having that type of a filler put in, even 5 years later. So I'm not a big fan of Bellafill with its plastic beads.
Makes sense. Devin, Emil?
Yeah, so I guess there's low level biostimulation and slightly higher level. So in Australia, we have something called Profilo. It's very banal. It's actually very easy to use, and it's very forgiving. So that's very low level biostimulation. Ophir Artsy's done several good papers. He's done 2 good papers on the use of Profilo, the high and low molecular weight. I think that you guys in the US will probably get it soon. And basically, the paper shows it's got a biphasic response. You get a response early on, but after 12 months, you get a better response. And part of it is due to the stimulation of fibroblasts. And if you can believe the actual research papers from 10 years ago, the stimulation of adipocytes, which I find it hard to believe. So look, that's one. It's a very easy one to use. I like using, like what Mark uses as well, the PLLA, your Sculptra. I also use a lot of CAH, which is calcium hydroxyapatite. So those are my main biostims. I think the PCLs are a little bit too inflammatory, so I don't use the polycaprolactones. We'll be getting some new stuff, so we're going to be having the poly-D-L lactic acid, the PDLLAs, which I think is exciting because it's got a higher concentration. And then there's the polynucleotides, which is a regerent for very superficial stuff and improvement of skin quality. So that's my working algorithm.
Actually, nanofat or fat injection that I mentioned are also very helpful. Complicated
Yes.
a bit when you have to harvest fat things you're doing.
Yes.
I kind of wanted to get into. I myself, I use Bellathil a lot, as you guys know. I love Bellathil. I think at some point we'll have to showcase some of the data because the studies that they have show that there's less chance of adverse events than HA fillers. And then I myself, I have a Bellathil on my face. I haven't really run into problems at all. Patients haven't run into problems. I think you got the point though is though, I think we all agree is that we have to do something for collagen stimulation, something extra. Which could be the Sculptra that we have or Radius, Bellathil. I think that we have to also investigate other potential possibilities, like we don't have Rejuron or what's the other ones you guys have over there, David, now that you guys
Profilo.
Profilo, yeah, I saw this release and that should be exciting. So at some point, hopefully we get our hands on that because I think that's going to be, that'll be really fun. I don't know, do you guys have that in India right now, Dhanraj?
We have Profilo, but we don't have any of the others.
Okay.
We don't have Sculptra, Radius, Rejuron. We don't have that.
Are you finding
Profilo,
that? Are you guys finding that it's lasting a long time for you?
Profilo is actually not long lasting. I think it's supposed to. Yeah, it's not. It's supposed to do collagen.
Yeah, I think it's like what Ophir says. It's possibly biphasic. You get it's more hydration, so you do get a wow within the first week or two, and then that continues for about 3 months. But in his study, which is very, very good, because he compared that against Voluma, Juvederm Voluma, and the biphasic response is nice. But it's still touch and go. I still use the old-fashioned, tri-tested Radius and the Sculptra if I need to actually correct volume loss as well.
Perfect. Yeah.
I like to mix Radius calcium hydroxyapatite with hyaluronic acid, and there is this new product, at least on the market in Europe. The brand name is Harmonica, where they do basically the same. They just mix it, and many of us have done it for years, but now it's finally approved. So, yeah.
Okay.
Yeah, I think it's kind of underutilized, to be honest with you, hyperdilute Radius still, even though I think we have the information now, but in the scar world, I think it's been a little underutilized, and I think it works really, really well, like to your guys' point, very, very nicely. And I like the idea, like you're talking about, Dr. Emil, of putting a little bit HA in there with it. I think it's really, really nice. I myself, I don't know if you guys have been doing it. I know Dr. Taylor actually does. I think Dr. Lim does too. But I like to use the laser channel holes and do really, really dilute forms of it. Is that right? You guys use that too, right? Dr. Lim and Dr. Taylor?
Yeah, occasionally, yes, yeah.
I think it works very, very well, actually. I kind of prefer more of that way now for scars a lot of times, of using the microchannels of lasers. And I found it's globally just like it looks so much better for patients' skin.
Laser-assisted drug delivery, right?
Yeah, it's. I think it's been amazing. I mean, obviously, like we know about it for steroids and things like that, but within this world, for doing this assistance with like Sculptra or like a very dilute form of it, or Radius, I still haven't figured out a way to dilute Bellathil, but at some point I'm going to try to figure that out too. But like, I think there's a really nice, robust result that we could get. Not like immediately. It's definitely not something that like people are going to get like, to you guys' point about the other products that you see like that wow effect for like that week. It's kind of like the opposite. Like it's like 6 months later, like a year later almost sometimes, But when you get it, it's like it's really, really nice.
Yeah, I actually mix my Sculptra with PRP. So I PRP combined and drizzle it into the create fractional laser.
That looks beautiful. Yeah.
Makes sense. Okay. I think if we've covered all the questions, we could call it a day today. So if anyone has to add like last pointers addressing patients, if we could go on, Devin?
No, I think we've covered a lot. So thanks for that.
Nader?
Yeah, no, I mean, just so everybody is aware, like we're very collaborative. We're going to try to do these more frequently, So if you feel like we didn't hit your questions, this was like our first time with this format too. So just, hopefully you excuse any like issues that we had with it. But we'll be happy to do this more and more. I think it's awesome to be able to collaborate. I think people should also know that like we do talk a lot, among our peers, and we try to openly discuss like any issues or like things that we try to look at. We're all very, very collaborative with that. And I think people kind of don't understand that aspect of medicine and science, that like we really are just investigating to learn and try to get like the best possible, safest results. That's what like literally science is about. And I love the fact that we have that kind of tight knit community over here.
Definitely. Emil, Mark?
Yes.
Yes, just say I appreciate this conversation, because we are really you feel a little bit stuck sometimes in this little niche, because you don't have many colleagues who work specifically with manual procedures. So I enjoyed it a lot. Thanks for that.
Thank you, Mark.
I enjoyed it as well. So I think that you're trying also with some precaution, not jumping on the bandwagon too early, because everything needs good support and good scientific studies to prove its worth.
Yeah.
But I think my message is look carefully at the patient, what scar do they have, and what's going to make a difference, and try to do as much for them as possible.
Thank you. Thank you so much, everyone, for being here today. And thank you to all our viewers for staying along and sharing your questions with us. And we plan, like Dr. Nadir said, we will plan to do more of this. Thank you so much for joining in.
Very good. Thank you.
Thank you. Thank you, guys.
Sure, guys. Have a good one.
Good night.